Uh, yes. Yeah. Good evening, everyone. Welcome you all to the monthly case discussion series hosted by Spice Route India Movement, Karnataka chapter. So today we are having a case discussion on respiratory case, and we have a presenter, Dr. Sakshi Khanna, who's a diploma family medicine student from Ballari. And our moderators for today are Dr. Srinath sir, who's a consultant general medicine from Ballari Hospital, and Dr. Hema Dasappa. She is an assistant professor, St. John's Medical Hospital, Bangalore. Welcome you all. We'll be starting the session. Sakshi, you can start presenting the case.
Thank you, ma'am. Good evening, everyone. Today's topic of discussion is a respiratory case. I would like to begin the case now. A 58-year-old male patient, Kumar Swami B, a shopkeeper, a resident of Kasai Street, Moti Circle, Ballari, Karnataka, belonging to middle-class family, was admitted to our hospital on 10th December with chief complaints of cough with expectoration since 3 days and shortness of breath since 3 days. The patient was apparently all right 3 days ago when he developed cough, which was insidious in onset, gradually progressive, with no diurnal variations or no positional variation. It was associated with expectorant, which was scanty, mucoid, non foul smelling, and non blood tinged. He also complained of breathlessness, which was insidious in onset. Initially, it was on climbing stairs or walking uphill, which was grade 2, and gradually it worsened to the current grade, where he was breathless on walking even for 100 meters. The breathlessness was also associated with wheeze and had no diurnal variation. There is no history of palpitations, chest pain, syncope. There is no history of fever, no history of paroxysmal nocturnal dyspnea, weight loss, loss of appetite, night sweats. No history of bilateral pedal edema, no history of contact with COVID positive patient. The patient is a known The patient is a known case of COPD for 5 years and had similar episodes in past off and on. The last episode was 3 months ago. He is a known case of hypertension and on medication. There is no history of tuberculosis, asthma, diabetes, no history of past major surgeries, and no history of drug allergies. Talking about the
Uh,
family history,
okay. We'll later again. Actually, you are presented in HOPA. Very good. Well, and actually, I want to ask you, like, when you are asking, like, you want to rule out the mainly of you are told like it is a respiratory case and all. I want to ask you, like, what are the cardinal symptoms of a respiratory system? Like, main things, you know.
sir, the cardinal symptoms of respiratory systems are mainly cough with expectoration, shortness of breath with
Okay.
wheeze, hemoptysis,
Then,
hemoptysis
okay.
and chest pain. Chest pain, sir.
Okay. Okay. Uh, like, like what you want to rule out, like mainly the respiratory systems here, these cardinal symptoms are very important. Like mainly cough with expectoration, like what are the mainly thing you will come to know here? Like what are the differential diagnoses you can arise with cough with expectoration?
Sir, I wanted to rule out the cardiac causes also, like pulmonary edema and all. Also, the infective causes I
CV.
want to rule out. Tuberculosis
Yeah.
I've ruled out, sir, because there is no history of weight loss, loss of appetite, or
Okay.
night sweats.
Okay. Good.
And also the cardiac symptoms I've ruled out because there was no history of palpitations, chest pain, and syncope, sir.
Okay. Fine.
I wanted to rule out
Okay.
the infective causes also, like pneumonia, sir, because fever is not there.
Okay.
So,
Um.
one
Like
minute, sir, I would like to interrupt here. I request all the
yeah. Yes.
participants, if you want to answer for the question that is asked by moderators, you can please type your answers in the chat box. And also, if you have any queries or any doubts, please type in the chat box. And request everybody to keep yourself on mute, please. Sir, you can continue, sir.
Yeah. Okay. Next thing is mainly respiratory causes you ask. No, what are the negative history here you have collected? Like, what are the other things you have ruled out here by asking the negative history? Which negative history you
Sir,
have asked here?
sir, weight loss, loss of appetite, and night sweats, sir, to rule out
Yeah.
tuberculosis and carcinomas of lungs, sir.
Okay,
Also,
fine.
sir, bilateral pedal edema to rule out
Okay.
pulmonary edema and cardiac causes of breathlessness, sir. Also, PND, sir,
Okay.
left heart failure to be ruled out because breathlessness can be seen there also, sir.
Okay. Like, have you asked about orthopnea here? Like, do you want to rule out any like orthopnea
Yeah, sir, orthopnea should also be, the history of
included?
orthopnea should
Okay,
also
fine.
be asked. Yes,
Okay, P and D always like go with this one. P and D, orthopnea and all. This all goes towards mainly of cardiac causes, right?
cardiac
Like
causes,
what?
sir.
Okay. Still, what other negative issue you want to rule out? Like main thing we'll get confusion is whether it is respiratory or cardiac causes, right? Mainly that
Yes.
one we can rule out by asking the cardinal symptoms. Okay. Then after going for cardinal symptoms, you want to rule out the cardiac causes. Like cardiac things if you want to rule out. Mainly that one is ruled out by asking the paroxysmal nocturnal dyspnea, orthopnea, as usual what you told like pedal edema and all. Okay. Like other than cardiac causes, which will cause the breathlessness, what are the other causes of other systems you want to rule out in case of like you want to rule out the breathlessness? You told like cardiac is fine, okay. Then you want to rule out any renal system and as well as gastrointestinal system.
Metabolic, sir, I would, metabolic acidosis can also lead to breathlessness or
Yeah.
ketotic breath, Kussmaul's breathing, and Kussmaul's breathing can
Okay.
be observed there. So
Okay. Fine.
that,
Okay. Uh, okay. Fine then. Ma'am, do you want to ask any other questions, ma'am? Hema ma'am and Suprita ma'am.
Yeah.
Yeah.
Yes.
Please go ahead, ma'am.
So, Sakshi, you said he is a known case of COPD, no? Why did you say so? How did you get to know that he has COPD?
ma'am, he was previously diagnosed as COPD case 5 years ago in our hospital only, and he had similar recurrent episodes, acute exacerbations of such episodes off and on in the past also, ma'am. He has been recurrently admitted under us. Last, he was admitted 3 months ago with similar complaints of cough and breathlessness, ma'am. So he has that evidence of
Okay. So,
COPD.
in
Is
your hospital only, it is diagnosed as COPD. Now,
COPD.
okay, tell me what are how do you come to a diagnosis of COPD from history? From history,
Ma'am,
how do you say it is COPD?
Ma'am, first of all, the symptoms of cough with expectoration, also associated with breathlessness, is one point. Second is that he is a chronic smoker, ma'am,
Can
which
you?
is the most.
Yes, yes,
Sorry, ma'am.
yes.
Yeah,
Continue,
go
continue.
ahead.
Go ahead.
He's a chronic smoker, ma'am. His pack rate of 4.8. So he's been smoking that. That points out towards the major etiology for COPD.
Hmm.
Also, ma'am, uh,
Okay, you said is cough, breathlessness, and smoking history. So, can you describe breathlessness in case of COPD, cough, and breathlessness? Why it is not asthma?
ma'am, asthma majorly will have, first of all, ma'am, age group. This is an elderly
What is
patient.
the difference?
Asthma,
Yes, very good.
then
One is age group.
seasonal variations, ma'am. Asthma will be having more of
Seasonal variations.
exacerbation. Yeah, COPD is more like a chronic, all throughout the year, we can see.
Throughout the year. Okay. What are the
Um,
other features? How is
ma'am,
the
he,
breathlessness in COPD? It's a progressive breathlessness, right?
right, ma'am.
It is a progressive breathlessness. Breathlessness is more than the cough, except
Yeah.
for chronic bronchitis. Hmm. And what about asthma?
Asthma is more of a sudden attack, sudden
Yes,
exacerbation,
they are
and
episodic. So
non-episodic.
asthma is more of episodic. So what is the clue here? Asthma and COPD. they are symptom free in between the episodes in asthma.
Yeah.
Whereas COPD, it is a chronic progressive breathlessness. And then
Yes.
response to treatment. Asthma, they respond beautifully to treatment. Whereas COPD, they don't respond so much. There is improvement, but they don't. It is not reversible,
Yes.
right? Hmm? So
Right.
in this case, why do you consider one is age is got most probably you didn't describe, but most probably he's got progressive breathlessness. That's why he's coming back again and again. So progressive breathlessness, and they will be symptom. They will not be symptom free in between the. There is no symptom free days. There is bad and worse days, but there is no symptom free
Symptom free.
days associated with cough, and it can be mucoid system, mucoid sputum. What about in asthma? How is the cough?
More of dry
How is
cough,
the
ma'am.
cough?
More.
More of dry cough, or they can have thick plug of sputum,
Phlegm.
scanty thick plug of sputum. Hmm? So here you guessed it easily because he had a smoking history. Hmm. But we do see many patients, especially women, who can come with similar complaints. Hmm. So
Yes, ma'am.
if they don't have smoking history, what are the other histories you will, uh, you know, get detailed history of
Ma'am, in case of
in
females, whether they
respiratory
are cook,
system, especially when they are coming. Very good.
ma'am, if they're belonging to rural areas, whether
Bio.
they are cooking on chulas which use coal and
Yes,
wood, so that smoke
yes.
exposure, whether they live in a house which has overpopulation and not properly ventilated.
There's a
And
response in the chat group saying aspirin can cause asthma.
it cannot cause asthma. It can precipitate, it is a trigger for asthma episodes. So asthma will have triggers like medicines, NSAIDs, ecosprin, and emotions, physical activity. That is also one differentiating factor. There is always a trigger in asthma. In COPD, there is no triggers, except they have a exposure to noxious gases. So let's continue what we were talking. So in chola cooking, that you will ask biogas exposure, and what other history? Noxious gases. What are
Cold,
the other
cold
exposure
climates.
to other things? Cold climate cause COPD.
No,
May
ma'am,
Basically,
cause
none of
dust, no?
dust.
exacerbation.
Which dust? So,
Dust.
which dust?
Any occupational history have you asked?
Yes. What
Occupational history will
Certainly.
help you here.
Sir. Coal mine workers, silicosis, asbestos, such exposures,
They
or
all cause fibrosis.
bicyanosis, bagus.
Yeah. They all cause particular occupational history,
Occupational, yeah.
asbestosis, mm, fibrosis and all. But COPD, wherever there is exposure of fine dust, like in farmers, fine dust, and carpenters, fine wood dust, hmm, and bakery people who work in bakeries. These are the people who are exposed to noxious gases. So in respiratory system, a detailed occupational history is a must. Of course, he is a smoker, but many a times they may not be, and along with the smoking they can have other exposures also, passive smoking at home, all this. Hmm. Okay, so shall we go ahead, sir? You have anything to
Yeah,
say?
yes. No, ma'am. We will go ahead. Mainly, like HOPA, they should come to know the conclusion, like what type of disease and all. At least provisional diagnosis to be done.
Yes,
So I think what all the history she has like asked is, it's okay. It's well and good, madam. And we'll go ahead again. Right now, still the still summary we are not yet gone. So right now she is still
Yeah, yeah.
presenting the
Let
past
her
history, I
continue.
think. Past history, family
Yeah.
history, I think. Okay, ma'am, fine. Continue,
Continue,
Sakshi.
Sakshi.
Personal talking about the personal history, he prefers mixed diet. His appetite is normal. His sleep is sound. Regular bowel and bladder habits. He is a smoker for last 12 years, and he smokes around 8 cigarettes per day. That brings his pack years to 4.8. There is no history of weight loss. He lives in a well ventilated pakka house with 2 members in each room. So I would summarize here a middle-aged man who currently presented with cough with expectoration and worsening of dyspnea from MMRC grade 2 to grade 3 with recurrent admissions in past for the similar complaints and is a chronic smoker, also diagnosed with hypertensive and is on medication for the hypertension. Uh, in the last, I would like to summarize with my provisional diagnosis as a disease of lower respiratory tract, mostly of obstructive pathology, acutely exacerbated due to smoking, currently not associated with any complications like cor pulmonale or type 2 respiratory failure.
Um, this will become your final diagnosis, not provisional diagnosis. What are the provisional diagnoses you have kept for this case? Provisional means before we are examining the patient, before we are touching the patient, only by asking the history, we should come to the provisional diagnosis. Here, the provisional diagnosis, okay, fine, it's belong to the respiratory system. Now, your differential diagnosis. Like, what are your differential diagnosis right now? It may be a COPD, okay,
As-
fine.
mm.
Next, it may
It could
be like
asthma.
it could be a asthma. Okay, fine. It could be even like bronchiectasis or fibrosis.
Yes.
Okay. So whenever you will summarize the HOPI and history and all. So you should tell that like according to your history and all. Still you are not yet examined. So we cannot come to the final conclusion of the diagnosis, right? What you are told is anatomical diagnosis, pathological and etiological, and as well as associated complication. This is your final diagnosis. Right now, you want based upon the history only, you should tell your diagnosis, differential diagnosis or provisional diagnosis. It belongs to respiratory system. That is okay, fine. What are the differential diagnoses I have kept for this patient? And they should go on to rule out this differential diagnosis by examining the patient, right? So what are the differential diagnoses we kept for this patient?
So could be asthma, bronchiectasis, could be sir, pneumonias, uh,
Okay,
could COPDs, the
okay, fine.
more likely emphysema,
Okay,
emphysema
fine.
like pictures.
Uh, okay, a little bit. We go in the past history you have mentioned. Okay, you told like he's a known case of COPD since 5 years, right? Like anything you have mentioned about the drug history here? Like I have asked about
So,
the drug history and
sir, for his COPD, he is taking formoterol and budesonide inhalers, 2 puffs, but he was
okay,
non-compliant with
okay,
that. And for his
okay,
hypertension, he is on tablet amlodipine for
okay.
past 5 years. Sir, he's a known case of hypertension also. That's all he is taking. Otherwise, no drug history as such, sir.
Okay, some of the drugs which may cause the exacerbations and as well as it will affect the respiration. Now, which are the drugs you know which commonly will prescribe the like to COPD patients and they'll again present with after 1 or 2 weeks with cough with expectoration or at least they'll present with dry cough and all. What are those drugs which commonly we prescribe before asking the COPD history? Have you know anything like for cardiac causes you used to prescribe those drugs? I have asked any like drugs like especially AC inhibitors, have you asked anything? Use of AC inhibitors, use of beta blockers and all?
Sir, I have asked about that, but he is not as of now consuming those drugs.
Yeah,
Not
good.
on ACE
Like,
inhibitors, not on beta
yeah.
blockers.
Mainly, like when you are presenting the respiratory case, mainly a drug history, you ask these drugs, especially. Most of the people, along with the COPD, they will be having some like coronary artery disease or ischemic heart disease. They may be taking the metoprolol by unknowingly or probably, or they may on any AC inhibitors. Okay. Sometimes these drugs also may lead to the recent start. Like, for example, is known case of COPD. For last 1 month back, he has got like MI and all. He is taking metoprolol. Again, he presented with cough and all. Okay. At that time, just change of drugs is needed, I think, but not for all. Some patients, AC inhibitors and beta blockers, should be avoided for some patients. Okay. Then you were told about the smoking index, right? Like, what is the difference between the pack years and as well as smoking index?
So pack year is number of packs smoked multiplied by the number of years for which he has been smoking. The smoking index is number of cigarettes smoked per day multiplied by the number of years for which he has been smoking. So smoking index is a
Okay.
better factor than the pack years, sir.
Okay, fine. Smoking index more than how many like BDs or cigarettes, it will be more harmful. Have you known or have you come across that one?
Sir, more than 100, less than 100 is mild, 100 to 200 is moderate, and more than 200 has severe risk, sir, of
Yeah, more
developing
than
lung
200 to 300 is
carcinoma, sir.
more. Yeah. Like whenever presenting the like this one respiratory case as well as especially COPD patients, always ask about the smoking history and as well as mention this smoking index or smoking this one pack years. Okay. Okay, fine. Like have you asked about any alcohol history here?
Sir, yes, sir. In personal history, I
Hello.
have also asked about alcohol history, but he is a non-alcoholic, sir.
Okay.
He's
Like
not
how come
consuming
this?
alcohol.
Okay, how come this alcohol history may helps in or may precipitate the COPD? Have you come across like this? Anything else previously? Like alcohol history, there'll be chances of like a chronic alcoholic, there'll be chances of aspiration. Okay, less likely. Very like some of the patients may aspirate. Okay, by aspiration they may get again pneumonia. Pneumonia again in COPD again it will cause the exacerbation. Okay.
Yes, sir.
Okay, fine. Then any family history? Have you asked like any history of tuberculosis and all?
Yes, sir. Family history. There is no history of tuberculosis in the family and no history of
Okay.
similar complaints or in the immediate family members, sir.
Okay. Okay, fine. Then family history or past history or drug history or like personal history you asked about any like nothing significant, right? Personal history also.
So just that he's been smoking for last 12 years. That is the main
Okay.
point, sir. Personal history.
Okay, then anything have you missed out? Hello, madam. Emma, madam. Anything have you
Yes,
missed out?
yes,
Do
sir.
you want
I'll
to ask
just
any
ask.
questions?
Yeah, yeah. I'll just ask her
Yeah.
two questions. So you have a chronic breathlessness patient, no? Chronic breathlessness patient. What are the DDs? And you're clear that this is respiratory system cause. As sir and you discussed, we are clear it is respiratory cause. In respiratory cause, what are the DDs for chronic breathlessness?
Ma'am, could be pleural effusions, could be
Chronic.
pneumonias,
This is the
could
pleural
be
effusion will go on for 5 years. He's been having breathlessness 5 years, no? So prolonged
ma'am,
history. What are the DDs?
um, asthma is one, ma'am.
Yes, asthma, COPD. Then somebody is typing bronchiectasis.
Bronchiectasis.
And one more you tell me. Very,
Very frequently you'll see in our Indian population. Fibrosis.
fibro.
Yeah.
Yeah.
Post
Hmm?
TB sequelae fibrosis. Yeah.
ILD, interstitial lung disease.
Lung
Okay.
diseases.
Interstitial lung disease. Yeah.
So we have already discussed differences between COPD and asthma. Now you tell me how will you differentiate between bronchiectasis and ILD in this patient? Why can't
Ma'am,
it be
bronchiectasis.
bronchiectasis? And what other additional histories you will add in your past history, drug history, keeping in mind bronchiectasis and ILD? Tell me COPD, bronchiectasis, what are the differences? How will you differentiate?
Ma'am, COPD is basically irreversible damage to the lung alveoli, airways,
Mhm.
and bronchiectasis is permanent dilatation of the
Yeah,
distal
that,
airways, ma'am.
that we know
The
clinically, symptoms wise. Hmm.
the sputum produced in COPD is
Yes.
more likely mucopurulent, whereas in bronchiectasis it will be like a triple mucus, which we say, ma'am. If we keep it at rest, there will be three layers of separation. It will be mucoid on the top and purulent at the base. And above that, there will be frothy discharge, ma'am. There, ma'am, cough will.
Hmm.
Actually, what is the definition of bronchiectasis, Sakshi? If you tell the definition of bronchiectasis, it's enough, I think, here.
So it is the dilatation of the bronchioles. Bronchioles.
Okay,
In emphysema, there is dilatation of the distal airways, distal to the bronchioles,
okay.
and here there will be the dilatation of the airways, like bronchioles
So,
mainly.
so they have a copious amount of sputum, no? They basically produce copious amount of sputum and they have recurrent infections and will
Recurrent in
produce a lot of sputum. Hmm? So
in a
what
year, how
about,
many? Yes. Sorry. Go
yes,
on.
sir.
Go ahead. Yes. Go ahead.
So how will you differentiate between ILD and COPD?
On the basis of history
Yeah,
or on the basis of examination?
history, not examination. We are still at history. And what additional for bronchiectasis ILD, what additional histories you will add? See, ILD is also progressive breathlessness, dry cough. They don't produce sputum, right? It is basically dry cough and progressive breathlessness. Hmm? And other histories you have to ask in ILD is what are the causes of ILD? It can be connective tissue disorders, it can be idiopathic, it can be drug, hmm, and other infections and other cause, infection induced. So drugs, what drugs you will ask? Which what are the drugs which causes fibrosis?
Ma'am, I'm not really
Commonly
sure of it.
used. Methotrexate, amiodarone, nitrofurantoin. These things causes fibrosis. And connective other symptoms of do they have joint pain or myalgia, skin tightening? All those things you should ask if you are thinking of ILD. And
ahead.
bronchiectasis in past history, what are the reasons for bronchiectasis? It is infections, right? Past pneumonias, childhood measles, all these things should be asked. So till history, you are saying chronic COPD, but if you take chronic breathlessness, then your DDs are, sir kept asking you DDs. Your DDs are COPD, bronchiectasis, ILD. Okay,
Okay.
so with examination, we should never go
Come.
by, always look patient fresh. Never go by past
Ashish.
diagnosis. Hmm? Okay,
Yes, ma'am.
okay. That's it, sir. We'll move on with the examination.
Yes, ma'am. Examination. Yeah, fine.
General physical examination. The patient is conscious, cooperative, oriented to time, place, and person. He is averagely built and poorly nourished. His height is around 155 centimeters. He weighs 48 kgs with a BMI of 14.8. BP was 140 by 90 mmHg in right upper arm. The pulse was 86 beat per minute, regular, normal volume, normal underlying vessel condition with no radial or radiofemoral delay. All peripheral pulses were also felt. His respiratory rate is around 20 cycles per minute, thoraco-abdominal type of breathing. His temperature is 37.6 degrees Celsius taken in axilla. There was evidence of pallor and grade 2 clubbing. There is no history of icterus, cyanosis, edema, lymphadenopathy, and no external markers of TB. On systemic examination, the upper respiratory tract, there
Okay.
was no evidence of deviated nasal septum.
Okay. We'll discuss about just general physical examination here. Okay. Like what you told here, like spoken about the built-in nourishment. Is there any is there any need here to ask about the built-in nourishment here? Or if it is, there
Sir,
is any need means what is the importance of like how is the built and how is the nourishment here?
Sir, actually, I wanted to rule out between the emphysema and the chronic bronchitis component of the COPD. In emphysema, the
Okay.
patient will be more of like pink puffers. So he will be
Okay.
underbuilt. He will be
Okay.
cachexic looking. In blue bloater, he'll be
Built
having
built will
peripheral.
be underbuilt, or if the build will be build doesn't affect no here. If he's a well built, then afterwards the nourishment will be lost, right? The build doesn't affect that much, right? What is the build
Yes,
there then? Build is the stature, right?
stature, sir.
Yeah. Next thing, like yeah, like general physical examination. Next, you have mentioned about the this one. What? Sorry. Like pulse, BP, and as well as this one regarding the respiratory rate. And they are told about thoraco-abdomen, right? Like thoraco-abdomen, most commonly in case of males, you will see. In case of females,
Sir, in males, we will see mostly abdominothoracic. In females, we will
yeah,
see thoraco-abdominal type.
yeah, fine. In case of females, when you will see abdominothoracic type,
So when there is underlying thoracic, like respiratory pathology, uh, pleural effusions and all, then that time, so it will be the vice versa thing. The abdominal will become more prominent. Abdominal muscles will take over.
okay, fine. Then anything else you want to tell? Any other causes for abdominothoracic breathing in case of females? Anyone in the group else? Okay, they'll ask this one. Read the different like causes of abdominothoracic breathing in case of females. I will ask you, and vice versa in case of males. I will ask you. Okay. Next thing you are told about next like commented about. I think this one external markers of tuberculosis. What are the external markers of tuberculosis you want to see in case of general physical examination?
Sir, any prominent lymph nodes, discharging
Okay.
sinuses.
Okay.
If Montoux was done, then the wheel would like to appreciate. So these things.
Better like don't mention this point in examination. There are so many skin manifestations of tuberculosis are there. Okay, like try to avoid this kind of like question like answering there. Okay, there are so many skin manifestations are there, and then the whole topic will be diverted towards that one. Okay, next like have you examined any pallor was there here?
Sir, yes, sir. It was there, sir. Mild pallor.
Okay, yeah,
Are
it
you
was.
sure of pallor, Sakshi? What do you expect in COPD?
Polycythemia, ma'am, one of the complications of
So
this
you have to be
polycythemia.
double sure when you say pallor in a COPD patient. Very
Yeah.
difficult to pick up.
Yeah.
And
Any
what are the
sinuses?
respiratory?
Yeah,
Yeah,
go
yeah,
ahead,
go
go ahead,
ahead.
go ahead. No, no, go ahead, no, carry on.
So, clubbing, what are the respiratory causes of clubbing?
Ma'am, sorry, ma'am.
What are the respiratory causes of clubbing? You say grade 2
Ma'am,
clubbing, no?
yes, ma'am. Ma'am, carcinomas, then again bronchiectasis, bronchopulmonary fistulas, COPD, asthma.
COPD.
Lung
Oh,
abscess. There's
Sakshi.
answers in the chat. Lung abscess emphysema.
Yes, very good. See, what causes clubbing? Either infection, inflammation, and malignancy. These are the only things which cause clubbing. So, does asthma cause clubbing? No, asthma does not cause clubbing. Does COPD cause clubbing? No, Sakshi, COPD does not. Simple COPD does not cause clubbing. So, respiratory
If you have
causes of
clubbing,
clubbing.
then your diagnosis will be again, it will go towards the ILD there.
Yeah.
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 Or you will have
Go ahead, man.
got bronchogenic carcinoma in him.
Carcinoma. Yeah.
Mm. Because he's a smoker also.
Yeah. Or you
Okay.
want to rule out are there any cardiac causes also there? Okay, go ahead.
Go ahead.
Next thing.
Go ahead, Sakshi.
Lower respiratory tract. On inspection, the shape of the chest looked like a barrel. It was bilaterally symmetrical. The position of trachea appears to be central. The apex beat could not be visualized by the naked eye. The chest movements were equal in all spaces. There were no dilated veins, scars, or sinuses. There was no crowding of ribs. There was no supraclavicular hollowing, or the accessory muscles of respirations were not active, and there was no intercostal indrawing. On palpation, all the inspectory findings were confirmed on palpation. There was no local rise of temperature. The trachea was confirmed to be central. The apex beat was felt in the fifth intercostal space, just medial to the mid clavicular line. The chest movements were symmetrical in all spaces. The measurements, the transverse diameter was around 28.5 centimeters, the AP diameter around 26, the chest circumference on expiration around 84. Uh, on the right hemothorax on expiration measured about 42 centimeters, and on inspiration it was 42.5 centimeters. The left hemithorax on expiration measured about 42 centimeters, and on inspiration around 42.5 centimeters. So the chest expansion on the right hemothorax was zero point 0.5 centimeters, and left hemothorax was zero point 0.5 centimeters. So the total chest expansion comes around to be 1 centimeter. The tactile vocal fremitus in all the areas, that is supraclavicular, infraclavicular, mammary, inframammary, axillary, infraaxillary, suprascapular, infrascapular, and interscapular areas, the tactile vocal fremitus was decreased. On percussion, a hyperresonant note was found. Liver dullness was elicited in the normal space. The liver span was around 14 centimeters, and the tidal percussion was negative. On auscultation, the vocal resonance was also decreased in all the areas, both on the right and the left side. Air entry was bilaterally equal, and there was a wheeze which was associated over the bilateral lung fields. The other system, CVS S1, S2 was heard, and there were no murmurs. Per abdomen was soft and non-tender, and there was no organomegaly. There was no focal neurological deficit. So my provisional diagnosis here comes out to be acute exacerbation of bilateral
No, 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 no.
obstructive
Don't tell your provisional diagnosis here. Here you should tell your final diagnosis.
final.
Okay. After your summary, that is provisional diagnosis. Now you have examined the patient and you have auscultated, palpated, inspection done. Okay. Then after all this one, you should come to a conclusion and you should diagnose the patient by the end of your case. Okay. Now you should tell here what is your anatomical diagnosis, what is your like etiological, or what is your pathological, then etiological, then any associated with complication. Right. Okay, fine. Then we'll come again. We'll start with again inspection, right? Like inspection, like you are told about upper respiratory tract and lower respiratory tract. Okay, like what are the upper respiratory tract? Like till what you will divide the upper respiratory tract, and till when you will call it as a lower respiratory tract.
So externally, the marker of differentiation between the upper respiratory and lower will be the cricoid cartilage or the glottis internally, sir. Above the level of the glottis will be upper respiratory, below that will be lower respiratory tract.
Okay. Then what are the things you want to examine in case of upper respiratory tract?
So first of all, I would be looking for a deviated nasal septum because it will be affecting the
Nasal,
air entry as.
nasal
Then
flare. Yeah,
nasal flare,
nasal
sir.
flare, nasal septum. Yeah.
Yeah, sir.
Next.
LNSI, sir. Then,
Okay.
sir, poor oral hygiene, whether there are any evidences of leukoplakia, which are the markers of malignancies also, sir.
Dental
Leukoplakia,
caries.
erythroplakias, dental
Okay.
caries, sir.
Okay.
And,
Have you examined for sinus tenderness here?
sorry,
Examination
sir.
for the sinuses, maxillary sinus,
Sinuses.
frontal sinus.
Sir, I
Yeah,
didn't examine that.
this one also includes in your upper respiratory tract examination. Okay. Next thing about you should rule out any dental caries is there or not. Okay. How does this dental caries and the poor oral hygiene will lead to the causes, or how it will lead to the any infection or not? Will it
Sir,
lead to
it can
any like
also
complication? Yeah.
Pneumonia, sir, it can exacerbate if there is
Some
aspiration.
okay, someone in group, someone has texted right now. Sore throat. Okay, next. Infective endocarditis, rheumatic heart disease. Okay, fine. Next. Streptococcal infection. Good. Next. Okay, good. Then any other things you want to examine? Tonsils and as well as pharyngeal wall and all. Okay. Any congenital anomaly, a cleft palate, anything is there or not, you should see. Okay. Then afterwards, you'll come to lower respiratory tract. Okay. On inspection, what are the things you have seen in lower respiratory tract?
So first of all, the diameters, the
No, no,
chest
no, 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 no.
shapes.
Where is the, like from lower respiratory tract, it will start from, you told, like, cricoid, right?
Yeah, sir.
Then any, do you saw any like swelling in the neck? Have you saw any swelling in the neck? Or
No, sir.
any tracheal deviation have you seen?
No, sir. The trachea was central and there was no prominence of the sternal heads or no abnormal mass seen as such.
Something called trial sign have you seen there?
So trail sign was
Uh,
negative here, sir. There was no prominence of the sternocleidomastoid head, sir. Tracheal
okay, okay.
cleft head.
Next, okay then. Have you told about the movement? Like on inspection, there is any equal respiratory movements for there bilateral,
Bilaterally, sir, it was equal. The
and the movement
respiratory
is
movements
decreased
were
or
equal.
is it increased?
So decreased movement, decreased
Decreased,
expansion. Yeah, sir.
decreased expansion. Are you sure? Movements I'm asking, not about the intercostal spaces.
So,
Respiratory movements is different, and the respiratory, so no, intercostal spaces is different. Okay, fine. Then any like dropping of the shoulder I have seen
sir,
on
yeah, sir.
inspection.
Drooping of shoulder. Yeah, sir. There was no evidence of drooping of shoulder. Bilaterally, everything was
Okay,
symmetrical.
okay, like you are told about the scar sinuses and all. Okay, fine then. Then have you seen the apical impulse in inspection?
Sir, the apical impulse on inspection, it was not visible, sir.
Previously you mentioned about nourishment, right? You told poorly nourished.
Yeah,
Then
sir.
it should be seen, no? If it is seen means usually in fifth, which intercostal space you will see. It's very
Sir,
difficult. No, you should guess.
in fifth intercostal space, sir, just medial to the mid-clavicular line, 1.5 centimeter medial to the
Okay,
mid-clavicular line.
fine. Like, have you examined about the spine here? Sorry, have you seen about, sorry, in inspection, right? Have you seen about the spine here?
Sir, the spine
Any
also
spinal deformity
curvature
was
was
there?
no, sir, no scoliosis, no lordosis. The spinal curvature was normal.
Any, have you seen about any like spinocerebellar like distance, anything like that? Abnormal spinocerebellar distance, anything like that? Any lordosis like that?
No, sir, no evidence of lordosis, no
Okay,
scoliosis, no
okay,
kyphosis.
okay. Then is there any like fullness of intercostal space here?
Sir,
Intercostal space,
crowding.
any indrawing, crowding, indrawing, fullness?
No, no, sir.
Where do you see the
Intercostal.
fullness of intercostal space? Fullness, like
Sir, in fibrosis, collapse, atelectasis, there will be crowding of ribs or
in
there will be
crowding and
approximated.
indrawing with the fullness of intercostal space, I'm asking.
There will
Someone
be
told like
full
pleural effusion. Good,
answer. There will be separated. Pneumothorax,
good.
pneumothorax,
Pneumothorax, pleural
sir.
effusion, hydropneumothorax. Okay, fine. Next. Okay, we have still 15 minutes left. So next, after inspection, we'll go out for palpation, right? In palpation, sorry, Emma ma'am, do you want to ask anything else, or will you go ahead with the palpation now?
We'll let her finish the examination, sir. I mean, you
She
and
has,
I'll ask.
yeah, she has already like finished, ma'am. She told all case full
Okay,
presented.
I'll ask a few things. See, does your you said it looks emphysematous, no, in inspection. Does your measurement confirm that? How do you confirm barrel shaped chest?
Ma'am, the ratio of the transverse diameter to the AP diameter uh, should be in the ratio of 7 is to 5, which was not in this case, ma'am.
It
The
is
the
not.
AP diameter was the AP diameter is increased here than the
Hmm.
transverse. The ratio
Yeah.
is not.
Yeah,
Also,
that
ma'am,
is what is barrel shape. No, what happens in barrel shape? The AP diameter increases. There is
increased.
hardly 2.5 centimeters difference, transverse and AP. So 5.5 by 7 is what? If you divide it is zero point 0.7, correct? So if you
Correct, ma'am.
divide this, you will get around zero point 0.9, which is more than zero point 0.7. So this is a barrel shaped chest.
What is the normal shape of the chest, Sakshi?
No.
Normal shape of the chest.
So
Anyone in
normally
the
the
group?
transverse diameter is more than the AP diameter normally.
Okay, I'm asking the shape. You
Bilateral.
are told about barrel shape. Any shape is there for normal? Anyone in the group? Elliptical. Good.
Elliptical.
Yep. They will. This one they will ask you what is the normal shape of the chest. And transfer diameter and is on ratio, ma'am has already mentioned 5:7 and all. Okay, good. Carry on, ma'am.
Then what is the inference of your measurement?
Ma'am,
Would you
the inference is that it is not a, unilateral disease, ma'am, because the chest expansion, everything is decreased in all the domains. So it is
hmm,
something involving bilateral lung fields, and
hmm. And
also the
is it hmm, yes,
the chest expansion is also, ma'am, less. So
yes.
bilateral lung
So
involvement is there.
so the inference is it is barrel shaped chest and the expansion is reduced bilateral. Hmm. So now tell me what is your final diagnosis you said? It is COPD, no? Mostly
Yes, ma'am.
emphysema. So what are the points suggesting you that it is emphysematous chest? What are the points
First,
in your
ma'am,
examination?
according to on examination, ma'am, as my diameter suggests that it is a barrel-shaped
Hmm.
chest. Secondly, the tactile
Okay.
vocal fremitus and vocal resonance bilaterally it is decreased in all areas. That is also suggesting towards COPD or most likely emphysema. Uh,
Okay.
then, ma'am, the V's associated with V's.
Okay, next.
And hyperresonant lung fields, sir.
Yeah.
Both
How do you say
there.
hyperresonant lung field? Yeah.
Ma'am, normally the on auscultation, what we hear the normal vesicular breath sounds, those are resonant sounds. When the sounds are more increased in intensity, like there is likely to be like heard directly
Is
into
that
the ear,
so?
more
Is
resonant.
that is that so, or there is some parameter for to tell you hyperresonant? See, when do you say hyperresonant? When your liver dullness gets obliterated, then you say it is hyperresonant. Normally, you get liver dullness in the fifth intercostal space, right? So there also you will start feeling resonant. That's when you say it is hyperresonant.
Okay.
So you cross check your liver dullness in fifth. If it is really hyperresonant, then your liver dullness gets obliterated.
Okay, ma'am.
Okay. So all other features are correct. Barrel shaped chest, decreased breath movements, decreased breath sound, hyperresonant note, and decreased tactile vocal resonance and premitus. These you're technically correct. It does fit into emphysematous chest, COPD. But will you, sir was telling, no, with you have to describe properly. What else you want to add to your diagnosis? He has clubbing. I would have said um, acute exacerbation of COPD and to rule out bronchogenic carcinoma because he is having pallor and clubbing. You can't fit clubbing and pallor with COPD.
Yes, ma'am.
Anything else you want to add, sir?
Um, Next thing is um, like how do you want? Shall we go about the treatment and management, madam? We have still 5 minutes
Yes,
left now,
yes, yes, yes.
so that it will be a complete.
Yes,
Little
yes.
bit.
Sure,
Yes,
sure.
ma'am. Yes, ma'am. Yes.
Sure,
Do you want to
continue.
add anything else, ma'am? Before that one, do you want to add anything, ma'am? Like for the diagnosis and
No,
all?
sir. I think better we go ahead to investigation and treatment. Then it will be
Yeah.
complete.
Yes. Like, what do you want to like? What are the investigations you want to get it done in this patient, Sakshi?
Sir, complete blood count, sputum culture and sensitivity, chest X-ray, and spirometry.
Sputum AFP gram stain.
So yes, sputum, AFB, gram stain, CB-NAT should be done
Yeah.
to rule out
Okay, fine.
tuberculosis.
Okay. In chest X-ray, what are the findings you have seen in this patient?
So the bilateral lung fields were there was pushing down of the diaphragm and hyperlucent bilateral lung fields were hyperlucent. The heart shape was mostly tubular. The bronchiovascular markings were diminished. So more than
Okay.
7 ribs were counted in each lung field,
Okay.
sir.
Do you want to get spirometry in this patient?
Sir, yes, sir. I want to calculate the FEV1 and FEV ratio on
How
basis
does
of
it will
that.
helpful for you in the management?
Sir, that would let me know according to the gold criteria in which category my patient is fitting, whether this is a mild, moderate, severe, or a very severe case, and that will allow me to manage the case accordingly.
Okay. Next, what are like other investigations you want to roll out? In case the clubbing is present and as well as the pair is present, what are the other investigations you want to get it done? Like ma'am was asking, no, ILD, what are the other causes of ILD and all? Ma'am, do you want to ask anything else in the investigation, ma'am?
Yeah. So, because of pallor and clubbing, we have extended. Oh, thank you, Suprita. So, pallor, how will you evaluate anemia? Some
So,
quick
ma'am,
2, 3 tests. CBC you have.
anemia,
What next you will ask?
the MCV, hematocrit, MCH, MCHC values to know, and peripheral smear, ma'am, to know what type of anemia it is,
Yeah.
whether it is anemia of chronic disease, whether it is microcytic, nutritional anemia. I would like to rule out those things.
Yeah. So you want to see microcytic, hypochromic, macrocytic, and normocytic. That will tell you the next further steps. Very good. So in a resource restricted setting, at least one retic count, peripheral smear, if you can get, that's a very good investigation for anemia to take you further. What about clubbing? So you have X-ray. Based on the X-ray, if you see something suspicious, then if there is real clubbing and chest X-ray is suspicious, then what would you order?
HRCT is just.
Yeah. Only if uh, there is a suspicious in chest X-ray. Hmm? Okay. Quickly, can you clearly define COPD criteria, spirometry? See, no respiratory disease should be diagnosed without a spirometry, asthma and COPD. We should not diagnose without spirometry. So, what are the criteria, COPD diagnosis spirometry?
Ma'am, the first expiratory volume will be less than zero point 0.7 and FEV1 is to FEV ratio will be less than 80% if it is a mild scenario. In moderate, it will be
Mild, moderate, we don't want. Diagnosis, the ratio FEV1 divided by FEC is less than zero point 0.7. And uh, with the if post bronchodilator, the ratio should not change. FEV1 can change with the ratio, with the bronchodilators, but the ratio will not change. Okay, the ratio will be less than 0.7. Hmm. Okay, so how do you treat COPD?
Ma'am, we can first ask the patient to quit smoking, and then we
Hmm.
can go ahead with the drug therapies. I would like to start
What
with the
drug?
short acting beta-2 agonist.
No, no, no.
Uh,
Ma'am is asking the treatment, not for acute exacerbation of COPD. Ma'am is asking for the long-term treatment of COPD.
See, you know gold criteria, gold treatment, no gold guidelines. So which
yes.
category will come to? How many
Great.
categories are there?
Ma'am, there are four categories: mild, moderate, severe, and very severe. Acute
Hmm.
exacerbation will lie under category 3, severe.
Hmm.
So there we can
See, it
start
has
with
changed. You go through this years. It is A, B, and E.
A, B,
Hmm.
and A.
So
Yes, sir.
E.
exacerbation.
Hmm. So it is based on number of exacerbation in the
Exacerbation.
past and severity of the symptoms. So for
Yeah.
severity of the symptoms, you have to take MMRC or there is a CAT score. Okay.
Yes.
So if the symptoms are less, exacerbations are less, then A. If the symptoms are more, exacerbations are less, then it is B. Symptoms may vary, but too many exacerbation, like your patient, no, he's keep coming into hospital. He's having too many exacerbations. So he's category E. So for this category, what will you give him? What is the main mode of treatment? COPD.
Inhalational corticosteroids with bronchodilators with
Corticosteroid, main
nasal
mode of
septum.
treatment for COPD. For COPD, it is bronchodilators. For asthma, it is
Okay.
steroids. Why? Asthma is hypersensitivity, no? So it is reversible. Steroids suppress the inflammation and it prevents further attacks. In COPD, it is a permanent remodeling. No, there is no question of reversibility. It is symptom relief, exacerbation relief. Your goal of treatment in COPD is symptom relief and exacerbation prevention. So for that, bronchodilators. There are indications for steroid. When you give steroid, when there is a component of asthma or eosinophils more than 250, or there is frequent exacerbation and you have put him on bronchodilators, both. What are the types of what bronchodilators you use? Long
Short
acting.
acting beta agonists, methylxanthines, long acting beta agonists.
See, a short-acting beta agonist role is very limited because they don't have the advantage of preventing exacerbation. So it is just symptom relief. So it is best to start them with long-acting bronchodilators like beta agonist, long-acting beta agonist like salmeterol,
Formoterol,
formoterol, and antimuscarinics, your anticholinergics,
ipratropium,
tiotropium
ipratropium.
like glycopyrium, all those things. So for your patient, no, is category A, combination of long-acting beta agonist and antimuscarinic. To start with, if she is still not responding, eosinophils are high, you can add steroid. But the main line of treatment for COPD is bronchodilators.
Yes, ma'am.
Okay, you go and read indications for steroids in read gold
Criteria.
Fine.
criteria and treatment. So you want to add anything? I just went on.
Yes, ma'am. What you told is all absolutely right, madam. Like, do you want to add any other anti-inflammatory drugs here? Or sorry, like, do you want to add any antibiotics? Most of the time, people are prescribing, right, in OPD.
Sir, I would like to go for azithromycin. It has
Okay,
anti-inflammatory property also, sir. So
okay.
azithromycin we can go for.
How many days you can give? Lifelong you want to give, or how many days in a week you want to give?
Sir, thrice a week we can give for.
Okay, like yeah, you can give that one. What are the other drugs other than inhalation? Ma'am has told like inhalation, like bronchodilators and all. What are the oral medications you want to give
So
if you want to?
methylxanthines we can go for theophylline,
Okay,
doxyphylline. Then
okay, okay, fine. Like, do you want to add any like this one? What phosphodiesterase inhibitors? Anything like that? Have you heard about?
roughly Zumast, sir, it is newly.
Roflumilast. Yeah, good. Someone has answered Roflumilast. Yeah, good. Next thing, what you want to add? Any other things? Like when do you want to add oral steroids? Actually, ma'am has told you to read that one. Uh, like what are the other precautions you'll give to the patient to avoid the exacerbation?
So smoking cessations. He
Okay,
should stop smoking. And
okay,
obviously, if the occupational history is as like ma'am told, fine dust exposure, that should be avoided. And if
okay,
he is on any beta blockers or drugs which
okay,
cause bronchoconstriction, that should be avoided. Also, sir, if
okay.
in any family member is tuberculosis positive, then he should maintain that distance from there. And for
Yeah,
keeping the COVID-19 picture also in mind, that precaution also he should take, wear mask whenever he's going outside.
okay, fine. And one thing actually we are missing in the investigations. If the patient come with exacerbation, right? We want to do even ABG also there. Okay. So you want to come to know that whether which type of respiratory failure, type 1 or type 2. Based upon the ECG, you will come to know whether it is type 1 or type 2. And as well as in case of exacerbation and type 2 respiratory failure, we'll go for again with NIV. Okay. I think most of the people we know that type 1 only hypoxia, type 2 hypoxia with carbon dioxide retention,
Hypercapnia.
hypercarbia will be there. Okay. So, and some of the drugs like we will use in case of like a type 2 respiratory failure, we'll use like astazolamide. Like along with that one, we'll use methyl so medroxyprogesterone acetate also for respiratory center stimulation and all. Okay. Along with that one, NIV we'll use. Okay. So that at least once a day ABG till the patient's having like coming out of the respiratory failure, we should do the ABG also. Okay. So that afterwards, if you want to rule out anything other else, you should do go for the ECG changes. Anything is there, go for 2D echo. Okay, to rule out any car pulmonary, any right atrium, right ventricular dilatation, anything is there or not, you go and you should complete our thorough investigation. If the patient comes with the recurrent exacerbation and type 2 respiratory failure and all. Okay. Do you want to add anything else, ma'am?
Nothing, sir. I think you have covered everything.
Um, okay, ma'am. Then
Somebody is
Anmol,
asking, oh, ma'am, you said not to diagnose COPD without spirometry. What do you do in a setting where there is no spirometry? See, you can use peak flow meter. So peak flow meter readings have to be, recorded at every visit. So you look for variations in peak flow meter variations. If they are not much varying, more than 200 liters, no, then it is COPD. If there is good variations with the treatment, then it is asthma. But still, it is a crude way of coming to the diagnosis. Whenever it is feasible, they are going to major hospital, traveling to cities, then you advise them to get one spirometry. That is very important. See, spirometry, no, it also helps. FEV1 value will help you to tell the prognosis and for diagnosis. For both, it's very important. But for time being, for short term, you can use peak flow meters. That is very cheap. 350, 500, you get it. You can keep in your clinic.
and as well as in case of COPD patient, most of the thing what we'll miss is we'll miss the physiotherapy. Okay, mainly in case of
Chest
bronchiectasis
physical.
and all. Chest physiotherapy is very as much as important. Okay, so always even teach about the chest physiotherapy also. Okay, then Anything else, madam? Anything else we have missed
As
here?
you said, we had missed out this information. Physiotherapy is very, very important for COPD. The physiotherapy is the one which improves the prognosis. So we must emphasize physiotherapy.
It is the least touched part, madam, in rural areas and
Yeah,
all.
yeah,
Yes, ma'am.
correct, correct, sir. See, simple
Do you want?
exercise,
Yes,
no?
ma'am.
Building their upper arms, lifting 2 liters water bottle, like push-ups, such things. Then spirometry, this intensive spirometry that you can use. Then walking as much as they can walk. Uh, these are simple exercises which you should emphasize.
I think we have briefly covered most of the
And
things, madam. Um I think thanks for choosing me as a moderator, madam. Anything
thank
else you want to tell, ma'am?
Yeah, thank you, Suprita. Thank you for this opportunity. And Sakshi, you were good. You are systematically presented. That is very important. Huh? But read more about the topic. And it was a very nice experience with you, sir. I look forward to many more sessions like this.
Thank
And
you.
at last, I want
Thank
to,
you all for
at last, madam, just for the exam point of view, I'll tell all.
hmm.
Like main thing is whenever you're presenting the respiratory case, mainly go with a good differential diagnosis. Okay, always they will ask you regarding the difference between the COPD and asthma. And next thing is they will ask you like difference between the COPD and ILD. Mainly they will ask you what are the difference. Mainly they will ask you the differences tables. They will ask you. Okay, they will not ask you the it's not investigation wise difference. They will ask you mainly history wise difference. Okay, so kindly read about the history wise differences and never ever forget to tell the grading of the breathlessness. That is the main basics things. If you fail there, it will be very difficult. Mainly always keep biting that grading of breathlessness on the tip of your mouth. And next thing is this minor mistakes, clubbing, pallor, whether it is associated with or not, that one you should not miss. Okay. And next thing is this past history. In case by chance or bad luck, if you got tuberculosis, kindly read the recent treatment of the tuberculosis. Okay. Okay, madam. Then thank you for
Thank you. Thank you so
yes,
much,
ma'am.
sir. Thank you, Sakshi, for
Yes.
nice case presentation. And thank you,
Okay.
Srinivas sir, and thank you, Dr. Hema, for the moderating the session. It was really
Okay.
good, and I hope it has helped all the participants, especially the case presentation and the discussion part. Thank
Okay,
you
madam.
all. Thank you,
Suprita. Thank
everybody.
Thank
you
you.
all. Thank you.
Good night.
Thank you all. Thank you, madam.